endoscopic monoportal technique. But these are certain challenges which we face secondary to calcified disc. One is the adherence of the disc to the nerve root. So it could be nerve root or dura. Then obviously it is hard disc, so it is more difficult to excise. And then the real pain is when you start breaking your instruments, dealing with these hard discs. So there is increased risk to your fragile instruments. For the operative techniques, the same position, I think no major change. However, I do not change the size of my scope if even pre-operatively, if I am aware that it is a calcified disc, I would go in for my traditional 6.9 mm discectomy scope, which is 15 degrees, and the working channel is 4.3 millimeters. So I won't go into the detail of monoportal technique, but what are the operative nuances for dealing with calcified disc? So you need to create more space. As endoscopic surgeons, we tend to, we do minimum amount of bone work and minimum amount of flavectomy. But here, you should do a little more space creation. Drill to make a wider interlamina window. So you need space when you're dealing with these, because more amount of instruments would be going in, number of instruments going in would be higher. Don't sit with small flavectomy. Go in for a larger flavectomy. Generally what we do is 1 to 2 millimeters of flavectomy, and then we expand and put our sheath inside. So dissect the root. Again, this is very important. Dissect the root and theca. But more importantly, see, you have to read the MRI, and if you are feeling that you have encountered a hard calcified disc, do not push and rotate your sheath. Avoid it. If there is an extruded soft disc, you first attack it and remove. I'll show it in one of my videos. Once the space is created after you remove the extruded disc, you start rotating the sheath to retract the dura. And if you still feel that the root is tight, do not retract the dura at all. And try to use endoscope osteotomes and upcuts for excision of calcified disc. Do not attempt using your traditional disc punch. It's going to break. So this needs to be avoided at all costs, otherwise you are going to injure the root or the dura. The Chinese have come up with this ultrasonic osteotome as well for the calcified disc. We do not still have it in our hands, but it appears to be a good piece of instrument. So now I'll just share the videos. So here is a hard calcific L5S1 disc on Sag. You can see a really dark colored image, routine docking. I try to go from lower down to up, removal of the fat, traditional dissection of the inferior part of the lamina, and drilling and then upcutting. Again, as I have told you, that try to create a good window. This I am just dissecting the, because the theca tends to be pushed up and the root is pushed up towards you. So I tend to separate it, and we attempt a good decompression before we attempt for any root retraction. So once this is done, I am now aware that I'm dealing with a calcified disc, but I'm also on MRI, I picked up that there is an extruded fragment which I'm trying to remove before I'm trying to attack the calcified disc. So this disc comes out, and once these disc pieces come out, there is more space and I can rotate my sheath. And following that, I'm creating a space. As you can see, the whitish part is the dark, hard calcified disc which I have to cut. So there's a hump which I'm trying to sort of thin out so that I can undertake internal decompression and flatten the hump. So once I have removed it, this is the final pulsation. I can very well see under the root to confirm that there are no further fragments. And here, after we had sort of removed the disc confirmed, there was a piece which had gone up, cranial migrated, and that we removed without the root retraction. So this was the final picture. Now coming to what is floating calcified lumbar disc. Well, by floating we mean there is no bony connection with the surrounding bone. And almost 30% of the calcified disc would be floating. So the annulus is basically calcified, but it is not attached to any of the vertebra. So here, like this is a typical floating calcified disc where the annulus typically is separately calcified. So this is another case, again severe symptoms. Removed the first part here. What I was trying, I put feel, but I was trying to put my sheath in. This was a mistake. So I realized that I won't be able to pass my sheath, so I extended. I'm upcutting the superior part of the superior articular process inferiorly, creating more space, and once more space is created, then I can sort of rotate my sheath to protect the nerve root. Now here you will see that it is floating. You will see that I am separating this calcified. I hope you are able to appreciate that it's a hard mass there, which I am trying to separate from all the edges, and I would then be excising it. So here you see this is a typical floating disc which is not attached to any other bony part. But obviously there is a good amount of stretch. And this is basically then it is just excision. So in the interest of time, I'll move forward. In all, we have had around 8 patients over last 1.5 years, 2 of which have been floating calcified disc. We've had good to excellent outcome and pain relief in all the patients over 6 to 12 months. All have been discharged in either a day or 2. One patient had severe out of proportion dysesthesia. However, it gradually recovered over 6 months. Fortunately, we have not had any dural leak, which is really good for us. And these are certain publications. What this publication by Cheng et al. Says that they've done a retrospective study of 28 patients, and 93 patients had an excellent to good outcome. Complications they suffered was 1 nerve root injury and 1 dysesthesia. So one needs to be careful. This is another study by Dabo et al. It's a popular study. What again it basically highlights is that almost 90% of the patients had excellent outcome when you're excising the disc. However, I am sure by this time you would have started asking the question that is it really necessary to excise the calcified part, or we can just decompress? So if you go through literature, there are proponents of both schools. One is to excise, and the reason why they say is to excise the calcified material is because if you're not excising, these patients who have not had an excision of the calcified disc would have higher back pain when just decompression is done. Now, I haven't mentioned in my lecture because of time. The classification for a floating disc is 1, 2, 3. Type 3 is where there is calcification within the intervertebral foramen. That is an absolute contraindication for endoscopic procedure. So high risk to nerve root when calcified disc is excised, there's no doubt about it. As far as instrument care is concerned, you need to be more aware when you're dealing with a calcified disc. There is more wear and tear. Now, what basically you can damage the endoscopic lens. So don't try to pull the calcified material, remove it along with the scope and let the sheath be in. And RF tip to be away from the lens to prevent heat damage. So to quickly summarize, it's an effective MIS technique for calcified disc, though there is a steeper learning curve. Do not attempt it in your initial few cases. Extra care while handling the root prior and during the excision. Handle your instruments with care, endoscope with extra care, and you can achieve good to excellent outcomes in more than 90% of patients.